Welcome to this Step 3 clinical knowledge review on the hospital admission process, brought to you by Roadmap to Residency. Admission questions look like simple checklists, but the boards use them to test your judgment about safety, patient wishes, and planning. Today, we will break down how the test builds these stems and how to pick the right next step quickly and confidently. Our goal is not to reteach all of inpatient medicine. It is to train your eye to spot the pattern and apply a rule. Before or alongside this video, review the inpatient medicine and patient safety sections of your major review books and a good question bank so the foundation is already there. Here is our plan. First, we will learn to write a complete set of admission orders using a memory aid so that nothing gets left out. Then we will build a focused problem list, talk through code status and decision-making capacity, and plan a safe discharge that begins on the very first hospital day. We will work several practice questions in the style of your question bank and walk through why each choice is right or wrong. Throughout, keep your review books and question bank close because this video teaches you how to use that knowledge on exam day, not how to replace it. Our first strategy is to write a complete set of admission orders, and the easiest way to do that is with a memory aid. The letters spell out the words admit, diagnosis, condition, vital signs, activity, nursing, diet, allergies, labs, intravenous fluids, special studies, and medications. The most common trap on the boards is an order set that looks reasonable but quietly leaves one element out. The right answer supplies the missing piece. So when a STEM hands you a long list of orders, run the memory aid in your head and hunt for the gap. A patient on a blood thinner with no full precautions, or a diabetic with no glucose checks, is pointing you straight to the safety order that was omitted. If you simply refuse to skip a letter, you will catch these every time. Strategy 2 is to build a focused problem list, because the boards love to test whether you can rank what matters. Turn the history and the exam into a list and put the most acute, life-threatening problem at the top. The right answer usually addresses that top problem first before the chronic issues. Then watch for the quiet risks the STEM buries in the social history or the medication list. A heavy daily drinker who is admitted needs a plan for alcohol withdrawal. A patient who has taken steroids for a long time needs extra steroid coverage during the stress of illness. A good problem list is exactly what catches these easily missed items, so read the whole STEM before you commit to an answer. Now let us train on STEM recognition. 3 patterns show up again and again. The first is the missing order STEM, where a full order set is listed and one safety element is gone. Map the orders to the memory aid, and the answer is the omitted piece, most often clot prevention, fall precautions, or glucose monitoring. The second is the code status STEM, where a patient who can think clearly states their wishes about resuscitation. The answer is to honor the informed wishes of a patient who has capacity and to document them, even over family objection. The third is the discharge planning STEM, where a newly admitted patient already has obvious needs for going home. The answer is to begin planning on the first day rather than waiting until the end. Let us work through our first practice question. A 70-year-old man is admitted with pneumonia from the community. The intern writes orders for the floor, the diagnosis, the condition, how often to check vital signs, bed rest, a regular diet, antibiotics, and oxygen. Importantly, the STEM tells you he has poor mobility and a previous blood clot in his leg. The question asks which order is most important to add. Before you look at the choices, run the memory aid and notice what is missing. Almost everything is there, but there is no order to prevent a new blood clot, and this is a patient at high risk for exactly that. Let us break this down step by step. Step 1. Spot the pattern. Run the listed orders against the memory aid. Admit, diagnosis, condition, vital signs, activity, diet, and medications are all present. The element that is missing is clot prevention, and this patient has both poor mobility and a prior leg clot. Step 2. Apply the rule. Every admitted patient needs a decision about clot prevention, and a high-risk patient should receive medication to prevent clots unless something forbids it. So the answer is medication-based clot prevention, which is choice B. Step 3. Eliminate the wrong answers. Choice A is a routine recheck that does not protect him now. Choice C treats a problem this STEM never raises. Choice D adds an unnecessary catheter and a real infection risk. The answer is B. Here is our second practice question. An 80-year-old woman with advanced heart failure is admitted with shortness of breath. She is alert, fully oriented, and she clearly explains that she does not want chest compressions or a breathing tube if her heart stops. Then her son arrives and insists that everything possible be done. The question asks for the most appropriate next step. As you read the choices, hold on to the details that matter most. She is awake, she understands her situation, and she is stating her own wishes clearly. Think about who actually gets to decide here before you look at the answer choices. Let us work through this answer. First, read the question carefully. The stem tells you she is alert, fully oriented, and able to explain her reasoning, which means she has decision-making capacity. A patient with capacity has the right to refuse treatment, including resuscitation, and her informed wishes control the plan. Now, why do her wishes win? Because a capable adult cannot be overridden by family, no matter how strongly they feel. So the next step is to document her wishes and write the order not to resuscitate, which is choice B. Following the son ignores her rights. Asking a court is unnecessary when there is no real dispute over capacity. A psychiatry consultation is for when thinking is impaired, and hers is not. The answer is choice B. Let us talk about code status and capacity, because the boards quietly test your judgment here. Start with who decides. A patient with capacity always decides for themselves, and their informed choice cannot be overridden by family. Capacity means 4 things. The patient understands the situation, appreciates the consequences, reasons through the options, and communicates a consistent choice. You should discuss code status with every admitted patient and document it early. Now, when the patient cannot decide, turn first to a valid advance directive, then to the named healthcare agent, and then to the next of kin in the legal order. A clear prior statement of the patient's own wishes outweighs what the family would prefer. The board answer always follows what the patient would have wanted, not the loudest voice in the room. Here is our third practice question. An 82-year-old woman who lives alone is admitted after a fall and has a hip fracture repaired on the first hospital day. Before this, she walked with a cane, and she has stairs at home. On the morning after surgery, the team is asked what best supports a safe discharge. The question asks for the most appropriate next step. As you weigh the choices, notice 2 things. Her needs after discharge are already obvious. She lives alone, she has stairs, and she just had major surgery on her hip. And the question is asking about timing, which is really asking when good discharge planning should begin. Let us break down this answer. Spot the classic pattern first. She lives alone, she has stairs, and she used a cane even before a major operation, so her needs after discharge are predictable from the very first day. Know the key distinction. Discharge planning is not something you start at the end of the stay. It starts on the day of admission. So the safe move is to consult physical therapy and case management now, which is choice B. Waiting until she is medically ready causes delays and a longer stay. Sending her home today is unsafe given her situation. Committing her to permanent nursing home placement on the first day is premature and takes away her options. The answer is B. Here is a high-yield test-taking pearl on capacity and safety. First, separate capacity from competence. Capacity is a clinical judgment that a physician makes at the bedside for a specific decision, and it can change over the course of a stay. Competence is a broader legal status that only a court decides. On the exam, the treating physician assesses capacity, so do not reach for a court order when a clear bedside assessment will settle the question. Second, remember 2 safety reflexes at admission. Every admitted patient needs a decision about clot prevention, so when a STEM hands you an order set, look for the missing prevention order. And every admission needs a code status conversation along with discharge planning that begins on the first day. Recognize these, and the management answers follow. That wraps up our review of the hospital admission process for Step 3. Remember the through line, write complete admission orders by running the memory aid so nothing is left out, build a problem list that puts the most dangerous issue first, honor the wishes of a patient who has capacity, and begin discharge planning on the very first day. For deeper study, review the inpatient medicine and patient safety chapters in your major review books and your question bank, and drill the admission orders, code status and capacity, and early discharge planning. If this helped you, please like and subscribe so more students can find it. And when you are ready for one-on-one guidance, visit roadmaptoresidency.com to work with our expert tutors and residency advisors. Good luck on your exam, and we will see you in the next video.